So again, a very important topic, and the reason I'm saying it's important is because students usually miss out on these topics. And request you to please go through this topic 2 or 3 times, because MCQs are frequently asked from these short topics, and these MCQs can be the decider whether you get the branch of your choice or you don't. So don't miss out on these topics. We're going to talk about skin and soft tissue tumors, and the first lesion which you're going to talk about is basal cell carcinoma. Squamous cell carcinoma I've already covered at various places. We've discussed oral cancers, we've discussed penile cancer, we've discussed lung cancer, squamous cell lung cancer. So squamous cell cancer I've covered at various places. I'm just going to briefly touch upon it here, but I want you to look at the other modules. Basal cell and malignant melanoma I will cover in great detail. So basal cell carcinoma is also known as a rodent ulcer. This is also known as a rodent ulcer because this lesion is locally invasive. It is locally invasive but does not show metastasis. It does not show metastasis. That is the unique feature about this lesion. It just burrows locally. It does not show metastasis, and that is why lymph nodes are usually absent and distant mets are also absent in these patients. Now, the risk factors for basal cell carcinoma, they are more common in white population. So, invariably, you will see that all skin lesions, all skin cancers are more common in the white population. UV rays are also a common risk factor for all skin cancers. And Gorlin syndrome is basal cell, is BCC nevoid syndrome, is basal cell carcinoma nevoid syndrome, that is Gorlin syndrome, can also give rise to basal cell cancers. Now, BCC or rodent ulcer can be of various types. So, the localized types are nodular, nodulocystic. Now, majority of basal cell cancers are nodular or nodulocystic. In fact, I'll show you an image of a patient which I had operated, and this was probably the first cancer surgery which I had done. I was in second year, and there was a patient with a nodular lesion over the scalp. And we didn't know it's a basal cell cancer. We thought that it is a sebaceous cyst, but when the biopsy report came, it was a basal cell cancer. Fortunately, I had all negative margins, so it was all good for that patient. Pigmented BCC can also be there. Then you can also have superficial or multifocal. And infiltrative type is the morphic type. And this morphic type releases collagenase 4. This releases collagenase 4, and this collagenase 4 dissolves through tissue, and that is why it is known as the infiltrative type. It can spread. So these are the various types of basal cell cancers which you should know about. The clinical features, we already discussed that they're locally invasive, but they don't show metastasis. And on examination, they will have rolled out pearly white edges. You have rolled out pearly white edges. This I've covered in the common ulcer module as well. Rolled out pearly white edges are there, and they are locally invasive but they don't metastasize. Also, you should know that the most common site for basal cell cancers is the face. And where in the face? Above the line joining, angle of mouth with ear lobule. So above the line joining angle of mouth with ear lobule, that is the most common site where basal cell cancers can occur. So let me just show you some images. This was the scalp image which I was telling you about, which was a basal cell cancer, a nodular cystic type of basal cell cancer. Another patient which I saw during my post-graduation, she had a basal cell cancer on the side of her nose. So again, the side which I was describing, above the line joining the angle of the mouth to the ear lobule. Now, the diagnosis is confirmed by a biopsy. And this biopsy can be taken from the edge, or some people even like to take punch biopsies for skin lesions. I've already shown you the punch biopsy forceps in breast cancer module. I've shown you the punch biopsy forceps as well. Now, these arise from the basal epidermoid cells, and you will get the typical palisading pattern, right? You will get the typical palisading pattern on histopathology. In basal cell cancer, this palisading pattern has also been asked in the exam. Now, the management of these lesions is surgery, is predominantly surgery. And in surgery, we carry out wide local excision. We carry out wide local excision. Of course, basal cell cancers have a tendency to recur because I told you they're locally invasive, which is why we tend to resect them wide. We go wide and we carry out the resection in these patients. When we do a wide local excision, we can do a flap repair. I've already shown this to you in the plastic surgery module. You can do a rhomboid or a Limburg flap in patients with, this was another patient which I saw during my post-graduation, a basal cell cancer. We did a rhomboid flap. This is a bilobed flap for the tip of the nose. So tip of nose, we can do a bilobe flap. But if it is in the eyelid, we can do a bipedicled flap there for eyelid reconstruction as well. Now, there are certain patients who show high-risk features in basal cell cancers. And high-risk features basically means that these patients will be more prone for recurrence. So high-risk features are, this you should remember for your exam, these have been asked in the super specialty exam. If the lesion is more than 2 centimeters in size, or it is at a location which can infiltrate into the cranium, so cranial extension if it is present, if it is secondary to immunosuppression, or if they are recurrent lesions. Now, we know patients who are on immunosuppression can develop skin lesions. In fact, these skin cancers are the most common cancers following immunosuppression. Most common was squamous cell carcinoma, but they can also develop basal cell cancer. Now, these are patients who have high risk features, and we need to get wider margins so that recurrence does not occur. Now, one of the surgical methods to deal with these patients is Mohs micrographic surgery. So, Mohs micrographic surgery can be done for any skin tumor. It is any skin cancer. I am telling it to you in basal cell carcinoma, but it can even be done for squamous cell. It can even be done for malignant melanomas. What exactly is Mohs micrographic surgery? So Mohs micrographic surgery is that in the theater, I'm going to shave off this skin cancer layer by layer. So I shave off one layer, and then there is a microscope inside the theater itself. So I'm going to analyze the slide in the microscope and see whether the entire tumor has been removed or still some tumor is remaining. If I see that tumor is remaining, I'm going to shave another layer. So I keep on shaving layer by layer till we get rid of the tumor. The advantage of Mohs micrographic surgery is that this is cosmetically better. Why is this cosmetically better? Because we are removing less tissue. Because we are removing less tissue. But what is the disadvantage of Mohs micrographic surgery? It is more time consuming, because every time you shave and then you analyze the slide under the microscope, it will be more time consuming. Now, where exactly do we do Mohs micrographic surgery? So the indications for Mohs micrographic surgery is if there are recurrent lesions, if the lesions are close to vital nerves where I can't just cut blindly, if they are close to vital structures, or if they are present over the face. These are the places where cosmesis is also important, and we carry out Mohs micrographic surgery. So we should also know that in basal cell cancer, I told you surgery is the mainstay of treatment, which I've already explained to you. And I told you that lymph node involvement is uncommon. That is why lymph node removal is usually not done in these patients. Radiotherapy has same effect as surgery, but radiotherapy is reserved for those patients who cannot tolerate surgery. So if you have a very elderly person who cannot undergo surgery, there we can use radiotherapy. For very early lesions, topical 5-fluorouracil cream can be used. So topical 5-fluorouracil cream can also be used in these patients. So this takes care of basal cell carcinoma. The next skin tumor which we need to talk about is malignant melanoma. Now, malignant melanoma, like I told you for other skin cancers, UV radiation, wide population are common risk factors, and you can also have a familial syndrome that is known as the FAM syndrome, the familial atypical mole melanoma syndrome. And if you remember your module on pancreatic cancer, I told you that in this syndrome, you can get melanomas, you can get malignant melanomas, but it can also predispose the patient to pancreatic exocrine tumors. So pancreatic exocrine tumors or pancreatic adenocarcinoma can also occur in this tumor. Now, the various types of malignant melanomas which you should know about, the first one is superficial spreading type. Now, in melanomas, there are two phases of growth. The first phase of growth is the horizontal phase, where it is not invading, it is just spreading horizontally. And then it starts to invade, which is known as the vertical phase of growth. Now, the superficial spreading type is the most common type of malignant melanoma. It is the most common type of malignant melanoma. It has a prolonged horizontal phase. It has a prolonged horizontal phase, so it has good prognosis. It starts invading later. This is seen in young patients and in sun-exposed areas. So like the face and wherever sun exposure is there, those areas are more commonly involved in superficial spreading type. So another point which you should remember is that this is the most common melanoma. This is the most common melanoma which develops in pre-existing moles. Which develops in pre-existing moles. And there is a case which I'll never forget. So when I was doing my fellowship in America, there was a lady who was 78 years old and she was diagnosed with breast cancer when she was 65. She underwent a breast conservation surgery, and 13 years later, then, she came back to the clinic and she had a mole just adjacent to the scar site of the BCS. And that mole was stable for a very long time. But in the last 6 months or so, it started increasing in size. And when we biopsied that mole, it turned out to be a malignant melanoma. So she had breast cancer, and just adjacent to that, then she developed malignant melanoma in a pre-existing mole. And it was a superficial spreading type of melanoma. So this, you can see, is a superficial spreading melanoma. This is what they look like. Lentigo maligna is the other type. Lentigo maligna is also known as Hutchinson's melanotic freckle, and this is the in situ variety of malignant melanoma. Because it is in situ, it has the best prognosis. Because it is in situ, it has the best prognosis, and this is usually seen in elderly patients. So you should know it has the best prognosis. Acral melanoma. Acral melanoma is the most common melanoma in dark-skinned patients. So in Asia, this is the most common melanoma in dark-skinned patients, acral melanoma, and this we can see in the palm, in the sole, palms and soles, acral melanomas can be seen. They have a rapid vertical phase. And that is why acral melanomas are aggressive in nature. These are aggressive in nature. Nodular melanoma. So nodular melanoma can present as a nodule. As the name suggests, it can present as a nodule. So it has a rapid vertical phase. And this has the worst prognosis amongst all melanomas. So worst prognosis is with nodular melanomas. You should know this. This has also been asked in the exam. So worst prognosis, and a variant of nodular melanoma is amelanotic melanoma. So imagine a melanoma which does not have pigment. So if it does not have pigment, it will just present as a normal nodule, a normal skin nodule. And you can easily miss this normal skin nodule. And that is why these patients present late. The final type of melanoma which has been mentioned in Bailey and the latest Sebastian is desmoplastic melanoma. And desmoplastic melanoma is commonly seen in the head and neck region. Perineural invasion, PNI, right? PNI we've discussed for various tumors. If you remember, in salivary glands, we spoke about adenoid cystic carcinoma as well, which has a strong propensity for perineural invasion. So this is seen in the head and neck region, extremely painful because of perineural invasion. And because of perineural invasion, there is increased locoregional recurrence rate as well. LRR is locoregional recurrence rate. So local recurrence rate is high in these patients. Subungual melanoma is a melanoma beneath the nail bed. And when you get a melanoma beneath the nail bed, this appearance is known as the Hutchinson sign. It is known as the Hutchinson sign. And one thing which I want to clarify here in subungual melanomas is that subungual melanoma's superficial spreading type is more common than an acral melanoma beneath the nail bed. So beneath the nail bed, superficial spreading type is more common than acral melanomas. This has been clearly written in the books. Now, you have a lot of patients who have moles. Even I have moles. So my identification on my passport is moles on both the cheeks, right? So people have multiple moles, and of course they get concerned whether it is cancerous or not. So what are the features which we need to look at which can tell us that a benign mole is getting converted into a melanoma? So these can easily be remembered as the ABCD features. A stands for asymmetry. A is for asymmetry in the border. B is, you look at the borders. If the borders are becoming irregular, C is color. So a change in color, a recent change in color is very important. D is diameter. So if the diameter of the lesion is more than 6 millimeters, then we need to be concerned. E is evolution. So evolution means that is there a change in color? Is there a change in color, size, border? Or you get a lesion which is now becoming itchy. It wasn't itchy, it is now becoming itchy and there is discharge from it. These are the various features which we need to look at. So these are the ABCDE features. You need to remember for them for the exam, which we should look out for in any patient with a melanoma. Now, to confirm the diagnosis, we will do a biopsy, right? We have to carry out a biopsy to confirm the diagnosis. So when we do a biopsy in these patients, you will see the various cells and you will see melanin pigment as well. And what we are looking at in the biopsy is the depth of invasion. Because that is one of the most important prognostic factors. Not the most important, I will tell you the prognostic factors later, but one of the most important because it helps us in managing these patients. Now, to confirm the diagnosis of melanoma, we can even do immunohistochemical markers. And the IHC markers for melanoma are S100, HMB45 and Milan A. So these are some IHC markers, immunohistochemical markers for malignant melanomas, and these have also been asked in the exam. Now, we need to know the depth because we need to know the staging of the melanomas. And there are two main staging systems. In addition to the TNM staging, you have the Clark and the Breslow classification as well. So both Clark and Breslow classification is based on the depth of invasion, So if you look at the Clark's classification, epidermis is stage 1. Papillary dermis involvement, epidermis plus papillary dermis is stage 2. 3 is when dermal papillae are involved. Stage 4 is when reticular dermis is involved, and stage 5 is when subcutaneous tissue is involved. So that is the Clark's classification. The Breslow classification is based on the depth. So Breslow grade 1 is when the depth is less than equal to 0.75 millimeters. 2 is when it is 0.76 to 1.5 millimeters. 3 is when it is 1.5 millimeters to 4 millimeters, and 4 is when it is more than 4 millimeters in depth, that becomes Breslow 4. So this you should remember, Clark's and Breslow classification you need to remember for the exam. This is in addition to the TNM staging which is there. Now the spread of malignant melanoma, it can either show local invasion, or it can show lymph node spread, which is why we have to carry out a sentinel lymph node biopsy or lymph node removal. And it can also show distant metastasis. And distant metastasis can occur to the lungs and also all atypical locations. So like pericardial metastasis can be seen with melanomas. Intestinal metastasis can be seen with melanomas. So melanomas can go to all atypical locations as well. Now the management of malignant melanoma, the first line of management is surgical management. And surgical management takes into account two things: the management of the primary lesion and management of the lymph nodes. So management of primary lesion, we follow the NCCN criteria to remove the primary lesion, and based on the depth we will take the margin status. Based on the depth of invasion we take the margin status. So if it is a 0.5 millimeter depth of invasion, then 0.5 centimeter margin is enough, right? If it is still less than or equal to 1 millimeter depth, then 1 centimeter margin is enough. If it is 1 to 2 millimeter depth, then 1 to 2 centimeter margin is enough. And if it is more than 2 millimeter depth, then 2 centimeter margin is enough. Clearly, books have written, NCCN guidelines have also written that more than a 2 centimeter margin does not reduce the LRR. So whether you take a 2 centimeter or a 3 centimeter, the locoregional recurrence rates would remain similar. So that is why even if the depth is more than 2 millimeters, 2 centimeter margin is enough in these patients. Lymph nodes. If lymph node is negative, we carry out a sentinel lymph node biopsy. In breast, I've already covered sentinel lymph node biopsy in great detail. I've told you the various ways how we can do sentinel lymph node biopsy as well. If lymph nodes are positive, then we have to carry out a lymph node clearance in these patients as well. So this was regarding the surgical management of malignant melanomas. Now, if it is a metastatic melanoma, there are a lot of immunotherapy options which are available these days as well. And the immunotherapy options, you have dabrafenib, which is a BRAF inhibitor, which is used. Trametinib is against the MAPK pathway. Ipilimumab is a checkpoint inhibitor. Also, interleukin-2 therapy has also been approved in patients with malignant melanomas or metastatic melanomas. So one more thing which I want you to know is regarding isolated limb perfusion chemo. So in this technique, what is done is that the limb is isolated and high dose of chemotherapy is given in that limb only. So we tie a tourniquet and we only give chemotherapy in that limb. And this is mainly used for locally advanced malignant melanomas. Which are not amenable to surgical resection. That means there are multiple satellite nodules or in-transit nodules which are there. In such patients, isolated limb perfusion can be used as one of the treatment methods of malignant melanomas. So if we talk about the prognostic factors for malignant melanoma, two questions have been asked regarding the prognostic factors for malignant melanomas. You should know in patients where lymph nodes are not involved, depth is the most important prognostic factor. Depth is the most important prognostic factor where lymph nodes are not involved or lymph nodes are not involved in stage 1. So in stage 1 patients, depth is the most important prognostic factor. But if lymph node is positive, then lymph node is the most common prognostic factor. In these patients. This is what you should know about. regarding malignant melanomas. Now, squamous cell carcinoma, I've already covered at various locations, but I just want to cover a couple of precursor lesions for squamous cell cancers. One of them is a sebaceous horn. Now, sebaceous horn is when you get a keratinous growth which is coming out, and this can be one of the complications of a sebaceous cyst as well. And if you have opened up Bailey, even by mistake, if you've opened up Bailey, you would have seen a sebaceous horn, because the logo of Bailey is a lady with a sebaceous horn coming from the scalp. And management of sebaceous horn is excision, and this can predispose the patient to squamous cell cancer. Marjolin's ulcers I've covered at various locations. Again, I would like to reiterate, this was a patient who developed a Marjolin's ulcer in a long-standing, so they can develop long-standing burn scar, varicose ulcer. These patients can develop a squamous cell carcinoma or a basal cell carcinoma. Squamous cell carcinoma is the most common. So you will have a scar over which you will get raised, everted cauliflower-like edges, and that will be a Marjolin's ulcer. Marjolin's ulcer, the management of patients with Marjolin's ulcer is surgery. Lymph node involvement is rare because of scarring, because there's scarring and blood supply to this is not very good. So lymphatic spread is also uncommon in these patients. We avoid radiotherapy in patients with Marjolin's ulcers. We try to manage them as much with surgery as possible. So this takes care of all the skin lesions. Now the second half of this module is regarding soft tissue sarcomas. Now soft tissue sarcomas, I want you to know certain most commons before I tell you about the risk factors and how do we manage these patients. So soft tissue sarcomas, you should know that the most common soft tissue sarcoma is a liposarcoma. Earlier it was malignant fibrous histiocytoma, now it is liposarcoma. The most common soft tissue sarcoma in children, is rhabdomyosarcoma, and the most common site for these rhabdomyosarcomas is the head and neck region. So head and neck followed by the genitourinary region is the most common site for rhabdomyosarcomas in children. The most common soft tissue sarcoma in the retroperitoneum also is liposarcoma. In the retroperitoneum also it is liposarcoma. That is why if you remember your module on common swellings, I told you that lipomas at certain places are predisposed to sarcomatous change, and those places were interscapular region, thigh and retroperitoneum. Okay. Now if you look at the etiology of soft tissue sarcomas, radiation exposure can predispose to soft tissue sarcomas, like osteosarcomas can also occur after radiation exposure. Chemical exposure, immunosuppression. So immunosuppression, we know that patients who have undergone transplants are at a higher risk of developing sarcomas as well. Long-standing lymphedema, we know the patient can develop Stewart-Trevis syndrome. We've already covered Stewart-Trevis syndrome in the breast module and in the lymphatic system module. This is a lymphangiosarcoma which can develop in long-standing lymphedemas. Viral infections, you can have Kaposi sarcoma, which can develop following viral infections as well. So this is the etiology regarding soft tissue sarcomas. There are certain syndromes which can also give rise to soft tissue sarcomas, like retinoblastoma syndrome, Li-Fraumeni, which is P53 mutation, neurofibromatosis 1, Gardner's syndrome. Gardner's syndrome we've covered in the colorectal polyps and cancer module. Gardner's syndrome, I told you, is a variant of FAP where these patients can develop desmoid tumors. And desmoid tumor is a soft tissue sarcoma over the anterior abdominal wall. That is a desmoid tumor. Gorlin syndrome. So we covered Gorlin syndrome in basal cell carcinoma as well. And Gordon syndrome, these patients can develop fibrosarcomas. So this is the etiology regarding soft tissue tumors. Now, soft tissue tumors, the clinical features of soft tissue tumors, the patient will come with a mass or they will come with a swelling, right? They will come with a mass or they will come with a swelling. They can come with pain as well if it presses on nerves. Now, the diagnosis of soft tissue sarcomas is confirmed by a core needle biopsy or a true cut biopsy. I've already shown you the core needle biopsy or the true cut biopsy gun in the breast module. So, core needle biopsy or true cut biopsy is how we confirm the diagnosis. A word of caution here that whenever we are doing a core needle biopsy in a sarcoma, we should place our needle biopsy incision in such a way so that when we resect the sarcoma, that needle biopsy incision is also removed. Otherwise, there can be a higher recurrence rate. So we should orient the incision or orient the biopsy in such a place so that it is removed when we are removing the sarcoma. Now, there are certain features regarding soft tissue sarcomas which I want you to know about. Now, soft tissue sarcomas, number one, hematogenous spread is more common than lymphatic spread. This, if you remember, we also covered in gastrointestinal stromal tumors, GIST, which is also a type of a soft tissue tumor. Their hematogenous spread was more common than lymphatic. Even phylloids tumors in breasts, lymphatic spread was uncommon. Okay, so lymphatic spread is uncommon in soft tissue sarcomas, except, so there are certain soft tissue sarcomas where lymphatic spread can occur, and these soft tissue sarcomas are malignant fibrous histiocytoma, angiosarcoma, rhabdomyosarcoma, clear cell sarcoma, epithelial sarcoma, and synovial sarcoma. So these are, and these you can remember as MARSes, the mnemonic is MARSes, and these soft tissue tumors tend to spread to the lymphatic route as well. And in these patients, we need to remove the lymph nodes. Otherwise, majority of the sarcoma spread via the hematogenous route. Now, hematogenous route, if it is a retroperitoneal sarcoma, liver is the most common site where it goes. Whereas if it is in the limb, if it is a limb sarcoma, the most common site where hematogenous metastasis is going to go is to the lungs. So you should know about this as well. The second thing which I want you to remember regarding soft tissue sarcomas, that they respect anatomical boundaries. They respect anatomical boundaries or compartments. Okay, they respect anatomical boundaries or compartments. So the advantage of this is that they will not breach through fascias. They might push the compartmental boundary, but breaching it is uncommon. So that is why compartmental excision can be done for sarcomas, where you can remove the entire compartment and you can get clear margins. And the third feature regarding soft tissue sarcomas, they have a very high loco-regional recurrence rate. In fact, when we were postgraduates, our professor used to teach us that sarcomas are defined by recurrence. That is the hallmark of a sarcoma. Recurrence is very common in these patients. Okay. So these are some points which you should know. The management of sarcomas. So management of these patients, you should first know imaging needs to be done. You can see a sarcoma. The staging can be done using PET-CT. And you should know that the grade of the tumor, is the most important prognostic factor. Now, if we talk about the management of these patients, so management surgery in these patients, we have to carry out a wide local excision to get adequate margins. Wide local excision should be done, and wherever possible we need to do organ preserving or limb preserving. So if it is in a limb, we should try to do limb salvage surgery rather than doing an amputation. So surgery is the mainstay, wide local excision. Radiotherapy can be given to reduce the loco-regional recurrence rate. Radiotherapy reduces the loco-regional recurrence rate. And chemotherapy, the chemotherapeutic options are methotrexate, adriamycin, ifosfamide, and dacarbazine. These are the chemotherapeutic options in patients with soft tissue sarcomas. Just a few words regarding desmoid tumor. Desmoid tumor, I told you, can be seen in Gardner's syndrome. And this is a soft tissue sarcoma which is seen over the anterior abdominal wall. It is seen over the anterior abdominal wall and can be seen, it can be seen in the region of a scar. In the region of a scar, this can be seen, desmoid tumor. And again, it is locally invasive. It is locally invasive. As you can see in this image, it can become very big in size. It can compress on the bowel structures. It can give rise to obstruction. It can give rise to pain. The management of these patients is wide local excision. But one thing which I want you to know here, tamoxifen has a role in patients with desmoid tumors, because these patients these tumors can express estrogen and progesterone receptors. So it has been seen that tamoxifen can reduce the size and can also prevent recurrences in patients with desmoid tumors. So this was regarding soft tissue sarcomas and skin lesions. Let's do some MCQs. Before that, for final year students, the short note which is asked is usually Marjolin's ulcer and rodent ulcer. Rodent ulcer, you know, is basal cell carcinoma. These are the two short notes which you should remember from this module. Which of the following features would raise suspicion of a squamous cell carcinoma? We know raised cauliflower-like edges are squamous cell. This I've covered in the common ulcer module. And when you're watching this module, I want you to correlate it with the common ulcer module as well. Rolled out pearly white edges are seen in basal cell cancer. Undermined edges are seen in TB. Punched out edges are seen in arterial or neuropathic ulcer. Which of the following is true regarding basal cell cancer? Nodular type is the most common. This is true. Prognosis is very poor. No. Mostly seen over neck. This is also not true. Punch biopsy? No. We can do punch biopsy, can be done, but most commonly we do excisional biopsy only, because these are so small. So either if it's very big, an incisional biopsy or an excisional biopsy. So punch biopsy can be done, but it is not the most common. In patients with basal cell cancer, Mohs micrographic surgery is indicated in which one of the following? So recurrent tumor, yes, it is indicated. Tumor more than 2 centimeters is high risk, it is indicated. Well differentiated tumor, no. Perineural invasion, yes, and involving the lip, it will be done, not when it is well differentiated. A patient notices a change in a previously appearing mole. Which of the following would point towards the diagnosis of melanoma except? Asymmetrical outline, yes. Change in color, yes. Depth more than 6 millimeters, no. Size more than 6 millimeters. And a lesion which wasn't itchy but has now become itchy and oozy, that is also a sign of a melanoma. Which of the following is the most important prognostic factor in patients with stage 1 melanoma? So stage 1 melanoma means lymph nodes are not involved. In this patient, depth is most important. But overall, most important prognostic factor for melanoma, and this is given in all the books, is lymph node involvement. If lymph nodes are negative, then the most important prognostic factor is depth. But otherwise, if lymph nodes are involved, the most important prognostic factor is lymph node involvement. So please remember this for the exam. That brings us to the end of this module as well. Thank you.